Professor Wilcox is the head of microbiology and research development at the Leeds Teaching Hospital. And he is also the lead for C. difficile infection in Public Health England. Thanks, Mark, for being here.
Hello, good afternoon, everybody, and good morning to those of you, including Alex on the other side of the pond. 15, 20 minutes worth about the burden of recurrent C. diff infection from me. It's only appropriate that one puts up one's potential C. diff conflicts of interest. It's quite a long list here, which reflects the fact that I'm really driven to find the best solution for patients going forward, and indeed the options. Increasing the options for patients going forward. I've also, as it says in italics at the bottom of this slide, been involved in co-authoring all the major UK, European and US C. diff treatment guidelines and diagnosis management guidelines over the last decade or so. So the straw that breaks the camel's back is the one-liner to summarise this cartoon. And in this case, you've got a patient, usually with an elderly patient with lots of comorbidities, and one can think often of friends or relatives who fit this cartoon. And then the antibiotic or antibiotics come along, and if the person is in wrong time, wrong place with respect to C. diff, then that becomes the straw that breaks the camel's back. And a slightly less cartoon-like picture to illustrate what's happening, but essentially people don't normally have C. diff on board. Only perhaps 1, 2, 3% maybe of the adult population are C. diff positive. So that's where the wrong place, wrong time comes in. If you have recently met C. diff, then see the antibiotic, or the other way round in close in time, that's where C. diff infection may well supervene. Against the background of a poor or non-existent antitoxin response, because it's the toxins that cause the disease, the toxins produced by C. diff. And the other crucial background is the damaged, depleted, dysbiotic gut microbiome. So we've gone on those oblong boxes here. We've gone from a dense, replete microbiome, outnumbering the number of human cells in us. We are more bacterial than human, fact. And those numbers become depleted and they get dumbed down in terms of their complexity. And then C. diff, which can't get a foothold on the left sort of microbiome, the replete, non-dysbiotic microbiome, it can get a foothold. Even worse, it flourishes, produces its toxin as we drift to the right here. And then importantly, up to a quarter, maybe even a third of patients who develop C. diff infection, again, in the presence of a dysbiotic microbiome, which will have been made more dysbiotic, sadly, by the conventional antibiotic-based treatment for C. diff infection. A bit of an irony using antibiotics to treat a disease caused by antibiotics. But also, if you still don't have an antitoxin response, then you're at risk of recurrent C. diff infection. And so, trying to put that quite simply from a patient perspective, that means, as far as my simple maths go, that about 4 out of 10 patients have an unsatisfactory outcome. A smaller number than 4 actually will not fail their treatment, their initial treatment, but they'll go on to get a recurrence. But the holistic view is 4 out of 10 have an unsatisfactory outcome. Even worse, between 1 in 6 and 1 in 16 patients are dead by day 30. Okay, cause and effect is difficult to ascribe here, but approximately half of those deaths are probably driven, at least in part, by C. diff. And remembering also the straw that breaks the camel's back. And yet, what do we have to manage that situation? Well, 3 +1. The +1 is metronidazole, no longer recommended. Therapeutic options for C. diff infection. And as I've already said, it doesn't really make an awful lot of sense using an antibiotic to treat an antibiotic-mediated disease, but nevertheless, that's what we do. Clearly, I haven't got time to go into outcomes of C. diff infection, but you can see they're categorised here into mortality effects at the bottom, lengthening hospital stay, which is the major driver of healthcare utilisation costs on the right, recurrent C. diff infection towards the top, and on the left, for thankfully a small proportion of patients, devastating when it does occur, need for surgical intervention to remove sometimes the whole colon, large intestine, or significant parts of it, which are clearly associated with poor outcomes in their own rights. Whilst we have made considerable progress in some countries at tackling C. diff infection, including the UK, things are going the wrong direction now since the pandemic, since and during the pandemic. And you can see here a 25% increase in the numbers of C. diff cases, in the rate of C. diff infection, driven largely but not exclusively by hospital onset cases, as shown in the second two bullets here. Even worse, if you just look at the bottom of this slide, the chance of dying, the case fatality rate in patients who've had COVID-19 in the 30 days before or after a C. diff infection, their chance of dying is about 2.5 times higher than if they have not had COVID infection as well as C. diff infection. And again, sadly, against a backdrop of decreasing case fatality rate at day 30 over the last decade in the UK, the last 12 months during the pandemic has seen a reversal of that phenomenon, with a significant increase in case fatality from 13.5% to almost 15%. And to summarise the last 4 major international C. diff treatment guidelines, starting with the 2017 US IDSA, and most recently the UK and EU guidelines. This just summarises what those guidelines have said. There is consensus about metronidazole. Goodbye metronidazole from a C. diff treatment perspective. It's a great anti-anaerobic drug, but its pharmacokinetics are terrible to treat C. diff. And that probably underlies why it's such a poor treatment option. Thankfully, all 4 guidelines agree on that. Vancomycin is missing on this table on purpose because all the guidelines recommend to a greater or lesser extent vancomycin. So I've just simplified things here. However, you'll see that in the EU and the IDSA US guidelines, the preferred agent is fidaxomicin, not vancomycin, whereas UK NICE, on a cost-effectiveness calculation basis, disagree with that. Bezotoxumab, which has had very, very low uptake since its regulatory approval. Again, a difference in opinion between EU/IDSA versus UK NICE. So remember I said about the backdrop of the increasingly dysbiotic microbiome, this time not being a horizontal line, but being a diagonal line to represent an escalator. This is an escalator you don't want to get on as a patient, the recurrence risk escalator. So your baseline risk, if you are treated with vancomycin for C. diff recurrence, is about 25%, which is what I've said, but get one recurrence and that risk for recurrence rises to 40, get another recurrence, that risk rises to about 60%. So an escalator one wants to avoid. Ideally, the sooner one can intervene and lower that risk of recurrence, the greater the dividend from a patient perspective. But also, your chance of dying of C. diff infection goes up by about 1/3 from baseline, and I showed you those baseline 1 in 6 to 1 in 16, depending on which data set one believes, that increases by a third if you start having recurrence C. diff episodes as opposed to just one initial C. diff episode. So the picture is clear that the patient is poorly served in terms of preventing recurrence, of treating recurrence, and of preventing mortality. So what does determine C. diff recurrence risk? Well, there's a modestly long list here, and I'm not going to go through each of these, but the important thing is that several of these, the majority indeed, we cannot alter. Can't alter the age, we can't alter comorbidities, we can't alter what strain affects the patient, infects the patient, etc. One can do something about modifying the damage to the microbiota, which is caused by antibiotic exposure. So use more microbiome-friendly antibiotics, for example. One can ameliorate the host response, the antitoxin antibody response. That's the basis of besletoximab approach, for example. But it is a pretty short list of modifiable approaches to altering C. diff recurrence risk. Keep that in mind from a perspective of M3, which I'll come back to. So this is just, I'm not going to go through the detail here, but this is the EU, the current EU ESCMID C. diff treatment recommendations. And you can see the first thing to say is there is only a very short list of agents, and I've summarized those already, so I won't repeat that. And you can see that if you move from the first initial CDI episode with in 4 different things, effectively approaches that are possible, if you count metronidazole as one of those, which I prefer not to, so it's 3 really, that list shortens considerably. In terms of an evidence-based list, it shortens still further. If you get 1 recurrence, it shortens still further if you've already had that first recurrence. So the summary of this for me is there is clearly room, given the unmet patient needs, for more treatment options, better treatment options to prevent recurrence, to address recurrence, than exist currently. Which leads us, nicely or not, depending on one's point of view, to FMT, fecal microbiota transplantation. So quite simply, trying to address that dysbiotic brown stuff by giving some fresh brown stuff to a patient. Sounds easy, not necessarily pleasant, but it has caught on, this approach, in various countries to a greater or lesser extent. However, as far as I'm concerned, this remains an experimental procedure, and patients need to be aware that it is an experimental procedure with serious life-threatening, life-ending consequences if things go wrong. And clearly, the system is designed to try and prevent that going wrong, but you can only screen the brown stuff, the fecal donor samples, for the things that you know to look for. You couldn't screen for SARS-CoV-2 until we knew that SARS-CoV-2 exists. And of course, that's now been added to the very long list of things that need to be screened for to prevent inadvertent transmission of pathogens. I'll give you another simple example. Adenovirus, which started to cause liver failure, particularly but not exclusively in children, just earlier this year. Until this year, no one was screening FMT samples for the adenoviruses that appear to be causing that problem. You read a lot about FMT. The enthusiasts will tell you that the efficacy rate is 90%. It's not. The efficacy rate is actually less than 70%. And you see the data shown on the top slide from well-controlled studies show about 68% efficacy rate in terms of preventing recurrence in a recurrence population, versus poor studies, poorly controlled studies, where you get a better result because the dice is loaded towards the FMT, for example. And this is not cheap. FMT, if you take full system costs, to screen for everything one needs to screen for, reject about more than 9 out of 10 of those screen samples. That should be your success rate when you screen samples, then the cost is over €3,000 as per published in 2019. That cost will almost certainly have increased quite considerably since then, because the list of things to screen for has increased, and of course because of economic conditions. So to M3, one slide to summarise M3's results in phase 2, which was a really elegant study looking at different dosages of M3. And if one looks at the high dose M3 group, this non-toxigenic C. diff strain called M3, then in the high dose group, dosed at 10 to the 7 C. diff, so 100 million for 7 days, then there was a 6-fold reduction in the rate of recurrence. You went from 30% risk to 5% risk. Actually, that 5% went as low as 2% if one just looks at the patients that became successfully colonized by M3. So not everybody given M3, the great majority do, but not everybody at the dosages used here became colonized. So obviously if you don't colonize someone, you can't prevent bad C. diff by having good C. diff, non-toxigenic C. diff, there in the first place. So I've got, I think, 2 slides left. My 4, and this was not a slide I prepared for this talk, this was a slide I've used many times before. The 4 key things one needs to keep in mind to address when optimizing the treatment for C. diff is the fact that it's a toxin-mediated disease. So switching off, blocking that toxin is crucial, as quickly as you can do that. Ideally, second bullet, by avoiding microbiome further damage, adding to that dysbiosis, pushing towards recurrence. And of course, third bullet, prevent CDI recurrence. And if one prevents recurrence, treats C. diff as soon and as effectively as possible, one has a chance of reducing that by far unacceptable mortality rate associated with C. diff. And from an M3 perspective, the only alteration to this slide that I made was to add what M3 is aiming to achieve. And you can see the 3 of the 4 bullets, M3 is aiming to do the right thing from a treatment perspective, from an optimization perspective. Bad news is we're all getting older. All the major economies, these are just European economies, European countries, will see dramatic increases in the proportion of their populations who are aged 65 or older in the next 30 years, 25 years or so. So you're looking at a 50% increase in that proportion of the population that is age 65 or more. That means a 50% increase in the sitting ducks or the camels, and I make no apology of using that analogy from a patient perspective because I think it's important, who are at risk of C. diff infection. So this C. diff is very unlikely to go away given those demographics if nothing else changes. It's going to get worse. Thank you for listening.